talk about a little bit of what Fadi just talked about, the venous arterialization as an option for our no option patients. So this is what we're talking about. This is like the true desert foot where there's no named vessel in the foot coming back. No target for bypass. Nothing that we can really try to reconstruct. White stop signs is something we see commonly in these patients. They are typically dialysis patients, older patients, diabetics. A lot of calcium in the foot and in all the vessels, which makes the procedure much harder. And so again, at this point, we have endovascular procedures, we have surgical bypass procedures, but beyond that, it's basically wound care, hyperbarics. There's not another procedure until now where we started doing deep venous arterialization sort of off the shelf for the first few years and now within a trial. So when we talk about venous arterialization, what are we talking about? We're basically talking about leveraging the veins as conduit. So we go from the artery, which basically is clogged, it's occluded. There's no good reconstitution, so we jump the divider into the vein and we reverse flow down into the foot via the vein. And some of the equipment here is the crossing device, similar to an Outback's type, works better than the Outback in this situation. Limb flow, I'm showing you the limb flow system here. You can do it off the shelf, like I said. I'll show you some cases like that. But limb flow has a snare on the left that basically is in the receiving in the vein. So you puncture it, pass a wire in there, and then snare the wire down. They have a nice push valvulotome that goes from an antegrade fashion, so it's forward cutting and can make the valves incompetent. That's important into the foot, into the arch. And then they have stent, covered stents basically. They do have a conical tapered stent that goes from like a 3 to 3.5 millimeter to a 5 millimeter, and the rest are 5 millimeters. So these are just some data from the early cases. You can see the pre and what the post looks like. You can see hyperspectral imaging showing improved flow and wound healing with the AV graft open. So this led to PROMISE 2 based on some good data from PROMISE 1 showing safety and effectiveness in terms of wound healing and amputation-free survival. We were aiming towards 120 patients. I think they enrolled 87 yesterday. So here's an example of an early off-the-shelf case. This gentleman had, basically just one vessel reaching the foot, and even that was pretty horrible. And so he had gangrene on top of his foot. We couldn't do it conventionally. So what we did was we put a balloon in the vein. At that time, we used an Outback or Pioneer, in this case, an Outback, punctured the balloon, passed the wire, made the AV fistula, and then using Viabonds down into the foot, you go pretty far, actually. You can see the flow. And in this guy, we didn't have to coil, but sometimes we do put coils so that the stealing phenomena is minimized and we force flow out to the forefoot a little bit more. And you can see this, he had a open transmetatarsal amputation. And over the course, probably 3 months, typically it takes these patients with granulation and then a skin graft, he was able to heal that and walk. Okay, I'm going to go through here. This is just interesting because this one, I didn't think we were going to heal, actually. This Achilles exposed, desiccating. And again, we did the same thing. I didn't have to go as far into the foot because I got pretty good flow into the heel area, so I stopped there. I didn't go all the way into the foot, and she also healed. Another example, so extensive gangrene, desert foot. Here, as we do these things, we try different things, and there's not a lot of people doing this, so we talk. So here I actually got antegrade greater saphenous vein access, and that connects to a medial marginal vein, which eventually connects to the lateral plantar vein. So I went around the loop here, delivered a balloon, punctured the balloon, dragged the wire out of the foot. So again, through the greater saphenous vein access. And then did the same thing. And this gentleman, we did coil. I don't know if you can make it out, but we coiled one of the earlier veins so that we could force some of the flow. And he actually had really good flow out into the forefoot, which you don't usually see right away. It does take a few weeks typically for this to mature and for some of the arterioles in the digits to start filling. Okay, and this gentleman I'm showing you because this is actually a gentleman that is in the trial. And so, again, similar anatomy. And you really want to have at least a TP trunk to do the communication. So here, this is actually flow into the foot. It's actually playing, so it's pretty bad. So here's the anatomy. It mirrors the arterial anatomy as well. But we always map it to make sure that the lateral plantar vein is a decent size. So we look for 3 millimeters. Surprisingly, you'll see some DVTs. So you want to make sure the vein that you're going to use is open. So and then during the case now, we've sort of evolved to where we try to get lateral plantar vein access first, as Dr. Hanau is doing in this video. And we do the venogram through that. You can see we pass a wire. Here, there's a second wire because we chose, there's different parallel veins. So we want the one that's closest to the artery. Here you can see I'm getting ready to plunge the needle into the receiving snare with a lymph flow system. After that, we drag that out of the foot. You can see the AV fistula created. Then we bring their sort of, this is their valvulotome, so all the way down into the foot. And then after we use their proprietary, stents, covered stents into the foot, into the ankle, you can see that flow. So again, busy slides, but I just wanted to put it on here. The procedure itself can be very difficult, and it's really because of the calcium. But I would tell you that what's more important is the team approach afterwards and communicating with, the whole team, wound care, podiatry, nurses, the family. Because otherwise they end up in another hospital or see a physician that's not used to seeing these and they get amputated. We've seen that a lot. Swelling is not unusual, it's common. You can use light compression. We typically do not touch, we don't touch the foot surgically for about 4 to 6 weeks at least, okay? The only reason to do any kind of surgery is if it's infection or intractable pain. Otherwise, we try to let it mature because we find that we get better perfusion into the digits and the forefoot as that AV fistula matures. Pain afterwards is still mind-boggling sometimes. Most of the time they do fine, but sometimes they do have pain, and the pain sources we hope are peri-procedural because those will go away fast. Sometimes it's due to edema, but the problem is sometimes it's due to ongoing ischemia. So we've learned that we don't want to take out whatever flow they have. We really try not to take out that flow in the course of creating our deep venous arterialization because those patients tend not to do well. So we like to preserve whatever little arterial flow we have and then make the IV fistula in a vessel that's not going to interfere with the present blood flow. And again, so if they have extensive gangrene, we do recommend open TMA. Don't close it because the skin can be under a lot of tension. Negative wound vac, pressure wound vac. And then when you start getting granulation tissue, then you do a skin graft with a wound vac and then heal. And what we also found is that if these grafts stay open for about 3 to 4 months, patients tend to do very well even after the graft closes. And there's theories out there that this is actually promoting a lot of collateralization. So when the graft does go down, those collaterals that formed in the reverse direction take over. And so again, these are the sites. We're lucky enough to be a site. And they enrolled, I think, 87 patients yesterday. And they, depending on what the FDA says, they can go up to 120. Okay, thank you.
Wow, fantastic. Yeah. So lots of questions about that, and I think all three of us do it. I don't know, Eric, are you doing this as well?
We do a little bit. Yeah, me and my surgeon do it. Yep.
Yeah. So, question. I mean, one of the challenges that we've had, Fadi, is in these kind of cases, post, it's the tremendous swelling. I mean, how do you deal with the swelling in these cases?
And this is just anecdotal from our experience. We have about 70 patients so far over the last 2 years. So a third of the patients will have no issues. A third of the patients will have severe swelling, and a third of the patients will actually have shrinking, which is mind-boggling to me. But we tend to actually put them on diuretics from the get-go, elevate the leg, and in a few instances, which is again challenging, we actually put ACE wraps because of the amount of swelling. Because swelling is, you have to know a little bit about the wounds if you're going to do this. Swelling is the enemy of healing and can make things a lot worse for a lot of those patients. So,
and having said that, Art, one of the things that's happened is exactly what happens is that when the family sees the swelling and the wound actually, in our experience, looks worse for the first 4 to 6 weeks. And Stephen Coombe is the one who told us, do not, debride the wound, do nothing to the wound, just nurse the wound. Can you comment a little bit about that in terms of why you think that happens and why the sort of this anecdotal thing that we're saying 4 to 6 weeks to wait?
Yeah, I mean, we actually haven't had horrible swelling, I would tell you, surprisingly, but we do use compression, and it's interesting because sometimes the compression makes it better because it forces the flow to the forefoot. So we've actually had videos where we have a Doppler signal, and when we put compression on, it actually gets stronger. In terms of maturation, I don't deal with AV fistulas from a hemodialysis standpoint, but I think it's similar, and I think that it takes some time for the It's been explained to me, and I still don't really get it. But so sometimes too much flow can be bad.
Yeah.
When you see the flow volume loop being too high, like 400, 500, 600, that blood is basically just shunting through the system and leaving the foot very quickly. So sometimes we coil, we put compression because we want that to slow down. Actually, spend more time in the foot, have more pressure to sort of blow out the little venule, the valves and the small venules. So I think that's what happens over that time period, and it may look worse because now there's actually flow getting there, and
Yep.
and the inflammatory, all the stuff can,
all
white
the
blood cells and
the
stuff.
radicals are
Is
released.
what I'm thinking.
The interesting was Roberto Ferrarisi's. We talked to him a few times when we did these first cases, and he was talking about the size of the stent that connects the artery to the vein. And he's very much against putting a 5 millimeter.
Right.
He wants us to be much smaller. And I could never understand how you gauge that. And I don't know whether you two have any tips on that, or Eric. Because what we started doing now is using 3.5s and really not more than that.
Right.
Because initially, we thought bigger was better, and definitely is not. So, and I think that's the flow dynamic. Is there any
Yeah.
recommendations in your experience?
We've had the same experience, and we've had better results since we've done the trial. I don't know if it's just because it's more of a team approach now and in a more formal setting. But yeah, we use a 3.5 in that trial, and then we use flow volume. So basically, we take
Exactly.
a lateral plantar vein. Afterwards, we Doppler it. There's a whatever way to do it. I don't know. But look at the flow volume loop, and we're aiming for like 100 to 200 for the flow volume. If it's too high, we tend to bring them back and start doing something, coiling something, checking, stuff like that.
Okay. And how do you survey these patients? That's always a challenge because they're going everywhere, especially in New York. So how are you surveying them?
So in the trial, they have, defined time point, like 2 weeks, and again, duplex, 1 month, 3 months. I'm looking at them every time they come in. I go by the duplex clearly, but I also, on exam, you typically get this monophasic signal, which is what you expect between AV fistula. So I make sure that's strong and just, keep in communication with them all the time because they do need a lot of hand holding. And if that graft goes down, we bring them back to the lab. If there's any question, we bring them back to the lab. But if it goes down, you can definitely salvage them pretty easily. We bring them back into our outpatient lab. I've done 4 now with a Rotarex device, and it works beautifully.
Mm-hmm. Any other questions from the audience? Regarding this technique. One last thing. What type of antiplatelet and what type of antithrombotic do you use? I know there's no data. I'm just saying.
Yeah. Typically, I'm still using DAPT, but if I'm worried or if they are low risk bleeders, and now with the data, I'm using dual pathway inhibition.
Okay.